Good afternoon, everyone. For those who don't know me, my name is Dr. Janet Delat, and on behalf of the SHSP Student Affairs Committee, I would like to welcome you to Public National Public Health Week. As some of you may know, the official National Public Health Week was last week, but due to our holiday and our break schedule, we decided to extend it and have it be this week. So as part of the celebration that's going to occur all week, the Student Affairs Committee, the Department of Public Health, and STUI have collaborated to organize several events for you. So tonight we have the pleasure of listening to Dr. Adam Block's presentation about the state of healthcare reform. On Wednesday, the Department of Public Health is hosting Dr. Peter Tessler, the Regional Medical Director for Quality and Safety at Westchester Medical Center, speaking. His title of his presentation is An Introduction to Patient Safety and Risk Reduction. And that's going to be held face to face at Skyline on Wednesday from 3 to 4, and it will also be Zoomed. And then on Friday, Stewie has organized an event at the Greenberg Health Center, which is in White Plains, and that's going to be about nutrition and health. And so for any of these events, if you're planning to attend, please RSVP so that the folks can plan accordingly. And there's a link that earlier today, the NYMC community received a message from Public Relations, and within that message contains links. And with those links, you can find the RSVP information. I would like also to recognize the efforts of Aline Marr, sitting right over there, and Cindy Jakubowski, who is not here, in helping us to organize this week and to get the word out about the week's festivities. As well, I would like to thank Public Relations for same, helping us to get the word out, and also to Educational Media for helping us with the Zoom, the recording, and the live streaming. Before I introduce Dr. Block, I would like to invite Dr. Ben Watson, Vice Dean of SHSP, and Dr. Mark Kittleson, Chair of the Department of Public Health, to say a few words. Dean Watson.
One minor addendum to Dr. Delat's introduction. Every week is Public Health Week around here. You guys are doing it all the time in every way, which is wonderful. But it's nice that we were able to set aside one weekend specifically to recognize public health. I also, on behalf of Dean Amler, who's not able to be with us this evening, welcome everybody to this event. The school is very proud to sponsor this. And also many thanks to Dr. Delat, the Student Activities Committee, STUI, and the faculty and staff of the Department of Public Health for organizing these events. So my remarks are notoriously brief. Welcome and enjoy the evening.
Thank you, Dean Watson. Let me get this here. I'm Mark Kittleson. I'm the relatively new chair, I guess I can still say that, within a year, of the newly aligned Department of Public Health. And I am absolutely thrilled to be part of this program, be part of NYMC, but especially be a part of the Department of Public Health. This is the best group of people, I think, collectively I've ever worked with. They are incredibly talented, and I think we're seeing today's presentation by one of those talented people. You know, so often, as Dr. Watson mentioned, every week is Public Week. I get a lot of people constantly asking, you know, what is public health? And I always try to make it, instead of answering them, I ask them questions. And here are some of the questions I typically ask them. Do you enjoy drinking clean water? Do you enjoy eating at restaurants? Do you support keeping mothers and children healthy? Do you support efforts to keep your workplace safe? Do you like the idea of reducing the number of deaths due to heart disease and stroke? Do you support educating the public about warning signs on cancer? I mean, all of this is public health, and then way more so. We are involved in so many efforts. And so it is just a thrill to be here. And again, I want to comment on the faculty who are here, who are observing. There's also a lot of people, I believe, that are live streaming this. Thanks for all the help. Thanks for the STUI, the student organization that is really taking the lead on so many different things. And just one last thing. I believe when you hear Dr. Block talk, he's going to give a baseball example. Now, I'm not going to shout out the answer because Dean Watson and I know the answers very detailed. So we'll see if anyone else knows that. So thank you. And
Thank you very much. Okay, so now I would like to introduce this evening's speaker. So Adam Block trained as a health economist at Harvard and then moved to Washington, D.C., where he worked for the Joint Committee on Taxation as a health economist. He helped craft language on the Affordable Care Act, particularly exchange tax credits and individual mandate. After the passage of the ACA, he moved to CMS, where he was the Director of Health Plan Policy for Exchange Plans. He moved to New York in 2013 and has worked as the Director of Medical Economics at Fidelis Care, the largest Medicaid managed care plan in New York State, and the Director of Strategic Analytics at Montefiore. Dr. Block currently teaches health economics and market and regulation at NYMC School of Health Sciences and Practice and guest lectures on all aspects of the U.S. healthcare system. Dr. Block has published in health policy and economics journals, including a January 4th, 2018 blog post in Health Affairs. Please join me in welcoming Dr. Block.
All right. So normally, thanks for the great introduction. I'm looking forward to being a part of Public Health Week, and I'm honored to be the speaker today. Normally, I would start off and just start talking about the Senate and the House Republicans and the Senate Democrats and all that stuff that went into making the Affordable Care Act what it was, and I will get into that. But I actually saw this book on my desk, which I've had for about almost 20 years, and it's one of my favorites, and I'm going to read you a couple of passages that are specifically related to health, that are related to public health. So this is a play by Bernard Shaw called The Doctor's Dilemma, and it is not anything that anybody has ever heard of unless you're me, but Bernard Shaw, does anybody know what he's most famous for writing? George Bernard Shaw wrote a very famous play called Pygmalion. And that was what the movie and show My Fair Lady was based on. And later there was an adaptation of that called Pretty Woman that most of you have probably heard of with Julia Roberts. Anyway, he's a relatively well-known playwright. And and he is famous for, obviously, for other things, and he is a 19th century English playwright. But he talks about all of the public health issues that I have studied over the course of my career. He talked about 100 years ago. And so I'm just going to read a couple of passages that I thought were prescient. This book came out in, I think it was 1908. Actually, it was a play that was first produced. And so what he said in just the amazing language that English playwrights have, that any sane nation, having observed that you could provide for a supply of bread by giving bakers a pecuniary interest in cutting off your leg, is enough to make one despair for political humanity. But that is precisely what we have done. And the more appalling the mutilation, the more the mutilator is paid. He who corrects an ingrown toenail receives a few shillings. He who cuts your inside out receives a few hundred guineas. And then another one that another quotation that I saw that I really liked was really related to public health and how important it is that we actually have public health practices and not just have medical practices. Patients are, for the most part, so poor that good advice would be resented as impractical and wounding. When you're so poor, it is useless to tell a man that when he is sick or his sick child needs is not medicine, but more leisure, better clothes, better food, and a better drained and ventilated house. That is what they need and not medicine. That is what they need and not medicine. So I just thought that those were two good examples of what we do in public health. And the point is that while we have a lot of complexities today with health insurance and electronic health medical records, a lot of the public health problems that we have are not new. They are problems that are as old as as old as civilization. So I just thought I'd give that little example, and with that, I'll start talking about the Affordable Care Act and some of my experiences and what it really looks like. So here's an overview of the talk. The talk starts off, we're going to talk about the goals and the pathway of the Affordable Care Act. What are some of the goals? What was it trying to do? What was the point of it? Was it trying to lower costs? And then we'll talk about key changes in US healthcare coverage. So did it do what it was trying to do, right? That is what we as economists try to measure. We try to measure what is the efficacy of something. And then the potential impact of Trump care. So any changes that are going to happen as a result of the election of 2016 with the Trump administration in 2017, what do we think is going to happen to the Affordable Care Act as a result of that? So those are the three things that we're going to talk about. So the first thing that we talked about is I think it is absolutely critical that we understand that health policy is cumulative and it happens slowly over time. There's been talk about single payer system for, really it started with Theodore Roosevelt about 100 years ago. But more recently it started again with Harry Truman. He tried and failed to enact universal health care coverage in 1945, but did something actually very important, which was that the IRS made employer-sponsored healthcare coverage exempt from taxation. And as a tax geek like I know, and we're probably all tax geeks because if you're not, you better be, because taxes are due a week from tomorrow. As a tax geek like I know, this is one of the biggest tax exemptions that are out there. People talk about mortgage interest deductions and all these charitable deductions. The biggest deduction that is out there is the fact that commercial health insurance is not taxable. You don't get taxed on it. So if I get, if I'm taxed at a 30% rate, which many people are, then I get $100 from my employer, I take home 70. If I get $100 of health insurance from my employer, I take home $100. That gives a preference to employer-sponsored healthcare coverage. And what we see is, as I would expect, as we should all expect, that health insurance actually went from 9% to 50% between 1940 and 1950. Employers responded to this. And that Medicare and Medicaid were established in 1965 to cover the poor and the elderly, to fill in the cracks where employer-sponsored health coverage was not covered. One interesting thing that most people don't know is that Richard Nixon, who is a Republican, actually tried and failed to enact universal health care coverage in 1974. And then a more famous attempt to enact universal health care coverage was in 1993 under President Bill Clinton, whose wife, Hillary Clinton, the First Lady, was spearheading the overall healthcare reform attempt. Actually, as most people know, it did not pass. But one thing that was created as a result of it, that was created on a bipartisan basis, what bipartisan means is that both Republicans and Democrats supported this, was the Children's Health Insurance Program, CHIP, which now insures 9 million children. And the states had began actually disenrolling in February, but funding eventually passed in late February. So what were the goals of healthcare reform when it began? So one of the goals was that there was going to be no change to existing coverage for the majority of Americans. Most people had employer-sponsored coverage, and the objective was for most people to continue to have employer-sponsored coverage. The thought was the employer-sponsored system was working pretty well, and we shouldn't change it because people will get mad. There were these things in 1992 called Harry and Louise ads. The entire Clinton care effort was an attempt to change the entire system for everybody. Wealthy people, middle-class people, poor people, and Obama learned from that and said, we are not going to do that. We got a lot of resistance from middle-class people that did not want, were afraid of the changes, and they said, we're not going to do that. We are only going to fill in the cracks. People that have few options or poor options for healthcare coverage, those are the people that we're going to try to insure. And they were going to expand coverage and improve the individual market. And the third thing that they said they were going to do, the Obama administration, was that they were going to pay for the bill. Now, what does that mean, pay for the bill? Well, what paying for the bill basically means is that you've got a benefit that you're giving out. You're expanding Medicaid. You're giving subsidies for the individual market. That is more stuff that the federal government is paying for. So therefore, your costs are going to increase, right? So if you want to pay for the bill, there's 3 ways to do it. If you're going to spend more in your household, what are you going to do, right? You actually have to earn more money, or you have to reduce other costs to pay for the new thing that you're going to buy, right? If you're going to buy a new car and you're spending everything that you earn, you want to buy a new car, you either have to go out and get a second job and earn more money, or you have to reduce the other costs that you have to make up for the fact that you're buying a new car. So that's what they committed to do. Or you could do a third thing, which is finance it with debt, right? Borrow money, pay it back later. Medicare Part D, which before the Affordable Care Act, passed in 2003, was the biggest healthcare change, was the last big healthcare change. That was not paid for. It was financed with debt. And the way that the Affordable Care Act actually financed itself, because it did cost an estimate of $900 billion over the course of 10 years, was three ways. It was about a third, a third, a third. The first was that there are these things called Medicare Advantage plans. About 25% of people on Medicare are in private plans. The federal government gives those private plans money, and those private plans give people health insurance. The federal government said, okay, instead of giving you this much money, we're going to give you a little bit less money. That was paid for a third of the Affordable Care Act. Another third was related to healthcare-related taxes. And this was a lot of the stuff that you heard about in the news. One was called the Cadillac tax. Any plan that cost over about $20,000 was going to get taxed. And there was a tanning tax on self-tanners. There were all sorts of things that were considered in the healthcare sphere of things that were going to be taxes. And then there were additional non-health related taxes. And these still are in effect, actually. One thing that passed was if you earn more than $250,000, there was a 3.7% tax, I think it's 3.2 or 3.7% tax on investment income. And if you earn more than $250,000, there's an additional 0.9% of a Medicare tax that goes on to your earnings. So these were all taxes, and these were the way that the Affordable Care Act was paid for. So it was paid for, and there were taxes that were associated with it, and there was also reduced spending that was associated with it. One important thing to note is that one of the things that we find in healthcare is that spending is out of control. And it was never the mission of the Affordable Care Act to control healthcare spending. The mission was to expand coverage, right? To fill in the cracks of healthcare coverage, to reduce the uninsured rate. So if I were to measure the efficacy, whether the Affordable Care Act succeeded in its mission, I would simply look at one number. Did the number of uninsured people go down? And we'll take a look at the before and after of that towards the end of this presentation. So a couple of interesting parallels, because 2008 was a wave year, and it's really hard to think of, I consider myself an economist, but it's really hard to think of economic policy separate from the political environment. And what you saw in 2008 was that there was a wave of Democrats that went in. With the new president, President Obama, there was an enormous takeover of the House of Representatives by Democrats and of the Senate by Democrats. And there were similar parallels in 2016 when Trump came into office and the Senate was controlled by, the Senate was and is controlled by Republicans, and similarly the House of Representatives. And there are parallels to the one major piece of legislation that President Trump has passed. And what that was in December 2017, there was a major tax reform bill that was passed. And there were a couple of parallels that I found interesting. The first was that both the Affordable Care Act and the tax reform bill passed on 100% party line vote, which means that not a single Republican voted for the Affordable Care Act, not a single Democrat voted for the tax reform. The second was that in advance of the passage in Massachusetts, which is the bluest state of all the blue states, it's the most Democratic of all the states, they elected a Republican named Scott Brown became the senator from Massachusetts. In 2017, Alabama, the most red of the red states, elected a Democrat named Doug Jones. So I thought that those parallels were interesting. And the other interesting thing was that the elder party statesman, Ted Kennedy in 2008, and John McCain in 2017, people that had run for president in the past, were known, had been in the Senate for 30, 40 years, were both not present for the vote. And they were not present for the vote for the same reason. Both Senator McCain still has brain cancer, and Ted Kennedy died of brain cancer. So I just thought that these parallels of what was happening 8 years ago and today were just relatively interesting. And the last thing is that senators were able to, because the margins were so slim for passage, what that means is that senators were able to pork barrel. Anybody know? That's like a inside the Beltway term. But does anybody know what pork barreling is? Any thoughts? All right. So basically what it is when senators have spending that they want for their specific district. They want an army base there. They want funding for their hospital from the federal government to go directly to their district. And they were able to say, I am not voting for this bill unless this happens, because they had a lot of leverage because the sides needed every single vote. So those are a couple of parallels between both the Affordable Care Act, which ended up passing in 2010, and the tax reform bill in 2017. So I want to, there's a couple of fun political pieces that I'm going to go through relatively quickly because I don't want to get too mixed up in it. However, I think it is, I'm going to talk about it and then I'll talk more about what the content of the Affordable Care Act is. The first is that there was a 60-vote majority that was needed to override the filibuster. There was a single Republican not present. And the single Republican that was not present was Senator Jim Bunning, the Republican from Kentucky. Now, not being present for the Affordable Care Act vote is the thing that Jim Bunning is second most famous for. Does anybody know, outside of Dr. Kittleson, and Nick Cameron, you clearly know, no, what he is first most famous for? Now, I should preface this by saying Jim Bunning is a famous baseball player. He's a famous baseball player, and that was so he was a professional before. So Jim Bunning is one of about, and Dr. Kittleson, you probably know the exact number of pitchers that have done this. He was a pitcher who pitched a perfect game against I believe it was the Mets back in the 60s. Was it 64? In 1964. So that is what he will forever be remembered. That is what he was first most famous for, second most famous for ditching the Affordable Care Act vote. And there were 4 senators that were just barely in office. And I say this because just to show that all of this, even the biggest changes are often, particularly today, done on the margins. Meaning like there was only a 60-vote majority. It passed 60 to 39. And 60 votes was needed, so you couldn't give up a single vote. And 4 of these senators were just barely in office. And I think this is one of those things where a picture speaks 1,000 words. This is Senator Robert Byrd, who was 92 years old at the time and looks every day of those 92 years. This vote happened on Christmas Eve, and it was freezing cold. I remember this. I was there. I was at the Senate that time. And he died just a couple of months later. So you could see he was just barely hanging on to his seat, and if this vote had happened a couple of months later, he would not have been present. So that was one. Number 2 was Senator Al Franken, who recently is most famous for being removed from the Senate for sexual harassment, or rather, he formally resigned. Before being most famous for that, he was most famous for being a writer on Saturday Night Live and Stuart Smalley. But that is not why he was just barely hanging on to his office. He was just barely hanging on to his office because when November 8th, 2008 happened, and President Obama was celebrating for having won the election, Norm Coleman, his opponent, was actually the one celebrating because he actually did not win in the initial count. He lost by 215 votes, according to as of November 18th. And he called for a recount, and actually there was a recount, and it turns out there were about 1,000 votes that were not counted, and he won the large share of them. And he won 1,212,629 votes to 1,212,317 votes. That is a 0.01% margin. So if just a couple, 200 of those votes went the other way, Norm Coleman would have been senator. There wouldn't have been a 60-vote majority. The Affordable Care Act would have happened. So if anybody thinks about not voting, your vote counts, right? These are just cases in point where your vote counts. And I think it's important to note that. So this is something that really happened by a thread. The next thing that happened by a thread, does anybody know who this guy is? Well, you can read it. Rod Blagojevich. I actually, when I was preparing for this talk, I actually just looked him up and wanted to see what he was doing. And so I'll talk about who he was and why this is important. So Rod Blagojevich was a guy with the audacity to try to sell the senator from his state, President Obama. He was the governor of Illinois. President Obama was originally a senator from the state of Illinois. And as soon as Obama won, he tried to literally sell Obama's seat back to him. Not only that, he knew that the FBI was tapping his phones. And he spoke about this on it. So if you look this up on YouTube, you can find a YouTube version of him speaking about a phone, about selling, with a bunch of expletives interlaced in it, but about selling his seat back to him. And I think he even said, "You got to give me Secretary of HHS," or something like that. So anyway, he later, after being caught for this, he was caught for it, but the Illinois State Senate or House, I'm not sure, Assembly, I'm not sure which it was, couldn't impeach him in time. So he actually got to appoint the senator. Now, he didn't sell the seat, but he actually was the guy that appointed the senator that voted for the Affordable Care Act before a special election could happen. So this guy, who is now serving time in federal penitentiary, he got 12 years. He's doing very well. His hair is completely white now. I saw a picture of him from about a year ago. He's due out in 2024. He was the guy that appointed one of the senators that voted, and he appointed him after everybody, literally everybody in the world, knew that he was trying to sell the seat back. And after that, he went on The Celebrity Apprentice. So that's him right there from one of the seasons of The Celebrity Apprentice. You guys know what The Celebrity Apprentice is? Yeah? Yeah? Donald Trump's show? All right. Okay, and the last seat was a seat held by Senator Ted Kennedy. And this is important for two reasons. One is that Senator Ted Kennedy called healthcare the cause of his life. It was something he was super passionate about. And he got brain cancer about a year before. He was actually supposed to speak at my graduate school graduation and couldn't make it because of the brain cancer diagnosis. And he died August 25th, 2009. The Affordable Care Act passed in March of 2010, so just 7 months after he died. There was a special election however, the original version of the Affordable Care Act passed after he died, but before the special election. And who was appointed for the special election to have his seat? He was actually just a legislative aide, someone that had never held a appointed office, a guy named Paul Kirk. So a legislative aide like me was actually holding the seat and actually gave the vote. So it wasn't an elected official that was holding the vote. And then in January of 2010, when the special election happened, Senator Scott Brown, who before this was most famous for posing nude in some magazine, and this is a tasteful piece of that, but he became the senator from Massachusetts, and currently Scott Brown is the ambassador from New Zealand. So he, in January 19th, broke the Democratic supermajority, meaning that there were no longer 60 votes. So my point in all of this is that all of these seats, and I could give you other stories, but all of these seats hang on by a thread. And similarly, the tax reform bills, a lot of the things that happen nowadays, they just happen on the margins, just hanging on by a thread, but they do happen. And so this is one of the more famous pictures of President Obama signing the Affordable Care Act in 2010. It was actually 4 bills because there was the major part that passed on December 24th, 2009, and then a reconciliation bill that passed with less than a 60-vote majority in the middle of March. So now I want to talk about actually what's in the bill. I talked about how it got here. We all know it's a big deal. I want to talk about what's actually in the Affordable Care Act. So we're all scientists, social scientists. We want to study how things happen. And I think it's important to note what happened here. So this is the state of health insurance in the United States in 2013. The Affordable Care Act passed in 2010, but it didn't actually go into effect. Virtually nothing happened before 2014, and then everything happened. Then Medicaid expanded, then the exchanges happened. So you can look as a pre-picture what was happening in 2013. And what we can see is 56% of the United States had coverage through employer-sponsored coverage. 13% of the United States was uninsured. This was the objective, to reduce this number right here. Medicare, 16% of the population. Medicaid, 18% of the population. The individual market was 11% of the population. And there's actually a decent portion of the overall population that gets their coverage through the VA and the military. This is not just a tiny portion. This is a pretty big portion of the population. It's also important to note that if you add up all these numbers, which I know our biostatisticians are, they do not add up to 100%. And that is by design, meaning that, how come, anybody thoughts on why they wouldn't add up to 100%? I know you know this answer, Jeff. Go ahead. Perfect. There is no reason that you can't have more than one of these types of coverage, right? And the classic example of this is Medicare and Medicaid. They're called dual coverages, right? People have dual coverage, and they would be put in both buckets because they actually do have Medicare and Medicaid. So it would be inappropriate to actually do otherwise. So we see all of the uninsured, we see this is the pre-situation. Now, one of the big things, this is sort of what I call I bucket the Affordable Care Act into two pieces. The show horse is the exchanges. This is what people talk about. Are premiums going up? Are premiums going down? And really, it is important. It shows that there is actually a thriving individual market these days, which is really interesting. And there are people that are getting their care through it that didn't have access to care before. But the workhorse is Medicaid, and I'll talk about that second. Meaning more people got insured from Medicaid than from the exchanges, even though most of the articles in the papers and stuff talk about the exchanges. And so what did the exchange do? Well, they said that you have to offer these 10 benefits beforehand. You could offer a plan that looked like it didn't offer maternity coverage. It didn't offer drug coverage. They said, oh, you have to offer this standard set of 10 benefits. You don't have to, if you get health insurance coverage, you will never have to pay more than $7,000 a year for coverage, even if you have $1 million in healthcare expenses. There's no annual or lifetime limitations, which means that used to be plans that said, you hit $100,000 in healthcare benefits, we don't cover you anymore, we're out. And then what happened to those patients? Well, did they get thrown out on the street? They didn't really get thrown out on the street. Medicaid just took over for them. So the federal government was paying for them anyway. So this is the federal government basically saying that if you're going to offer a health plan, you got to offer a real health plan that has no annual or lifetime limits. And that premiums, pre-existing conditions were no longer something that you could offer change premiums on, that you could only look at it based on age, location, and smoking. New York State. What is interesting about New York State? Any of my insurance mavens? Anybody that's bought insurance in the New York State before? New York State, you cannot age rate. It is community rating. So a 20-year-old and a 64-year-old pay the same amount in premium. Sad 20-year-olds, happy 64-year-olds. But yes, it's the only state. Massachusetts, Maryland, other blue states do not do this. I believe Vermont does as well. But they're the only two states in the union that have what's called pure community rating. Health insurance exchanges, they permit direct comparisons between plans. Before the exchanges came out, you could not really look at two plans together and know whether they were similar in value. One might have a deductible of $2,000, but you don't pay anything else. And another might have a zero deductible, but every time you go to the doctor, you pay 50 bucks. Which is better? I do this for a living. I don't know. So in the Affordable Care Act, they made a calculator that stuffed all those plan benefits in and said, oh, these two are platinum, these two are gold, these two are silver. To say, okay, if we stuff all the benefits in, they actually come out to be worth about equal. So this permit comparisons between plans in a way that you could never, ever do before. And that is one of the requirements of having a competitive market, right? I would consider the market for shampoo a competitive market. You go in and you look at all the shampoos on the rack at CVS, and you can see what the ingredients are, and you can see what the prices are, and you can see what the volumes are, what the size is, right? That is a competitive, working, functional market. But if you didn't know how much was in it, right? You didn't know all these pieces, you would say it's not functional. So this permitted the market to be more functional, permitted consumers to be what consumers are supposed to be, which is active, thoughtful consumers about what they're purchasing. So what do you get? So we hear about healthcare subsidies, tax credits. This is what you actually get. And it's pretty complicated, but we'll go through it. So what you get is you get a tax credit. One of the purposes of the Affordable Care Act was to say to people like my barber, you're going to get a fair premium, right? If you have diabetes, you're going to pay the same amount as somebody that doesn't have diabetes. But I recognize that you earn $45,000 a year, which would be considered a middle for a single individual, which would be considered a middle-class income. 250, 300% of poverty. Well, actually, I guess we know what 300% of poverty is. 400% of poverty. But I recognize the fact that health insurance premiums can cost $500 a month, and $500 a month is not affordable for somebody that makes $45,000 a year. Therefore, we're going to give you a tax credit to reduce the cost of what you have to pay to something that is affordable to you. And so, how did they do that? They also wanted to encourage shopping, right? Meaning that if you have one plan that costs $600 a month and another plan that costs $500 a month, well, I want to encourage you to buy the cheapest plan that works for you. But if you want to buy the more expensive plan, I want you to be able to take your money and do that, right? So they created they said that, okay, here's what you have to pay. You have to pay a certain percentage of whatever the second lowest cost silver plan is. That is the benchmark plan. So if the second lowest cost silver plan costs $400 a month times 12 months, then your annual cost is $4,800 a year. Then there's a little, they call it a graduated table, and it says, okay, well, how much do I earn? You earn $36,180 a year. How many people are in my family? One person. Okay, well, 100% of the federal poverty level. If you're at poverty, this is the federal poverty level, comes out every year, is $12,060 for one person. If you earn less than that, you are considered to be in poverty. If you earn more than that, you're not considered to be in poverty. But in reality, people can have trouble paying for their bills if they earn substantially more than that. So what they said was, okay, at 300% of poverty, you're earning $36,100 a year. The law says that you will have to pay 9.5% of your income for premium. So what is 9.5% of $36,180? Well, that is $3,437. That is the amount that you are responsible for if you make $36,100. The problem is that your premium costs $4,800. So the amount that the federal government is going to give you a tax credit is for the difference between this $4,800 that your premium costs and this amount down here that the federal government says you have to pay. So this is the cost of the product. This is the amount the government says you have to pay. The difference between number one and number two is the amount that you get. Congratulations, you have a tax credit for $1,563. The nice thing is, with that $1,563, do you have to buy any specific plan? You have to buy the second lowest cost silver plan? You don't. You can buy whatever you want. You can buy a more expensive plan, and then you pay more than this per year. You can buy a less expensive plan, and then you actually can pay less than this per year. So the money travels with you. And here's just an example. And these are actually pretty reasonable. One thing that I try to do in all of my courses is I try to use numbers that if they're not exactly right, they are within a couple of percentage points of being right. Meaning that platinum premiums are frequently $6,000 for or $500 a month. Right? Gold premiums, these are common amounts for premiums. Now, if you wanted a platinum plan, it costs $6,000. You get your tax credit of $1,563. You have to pay $4,400. That's $370 a month. If you want the cheapest, the bronze plan, that's $4,200 a month. It would only set you back $220 a month. So that's real money in savings, right? So if you want to buy the more expensive plan, you got to pay more, $370. If you want to buy the cheaper plan, it's only going to cost you $220 a month. So that's the way the tax credit works, and that's the way that the tax credits enhance people to shop, because every dollar in premium savings that they get, they actually get to keep in a reduced premium payment at the end of the month. So it is important to note that the cost of insurance is still high. Someone earning 4 times, and now my previous example was for a one person, meaning a one-person family. I'm using an example of a 4-person family here. 4 times 400% of the federal poverty level for a 4-person family is about $100,000 a year. But the person takes home pre-tax $6,200 per month, and they need to pay $770 of that for healthcare. $770. Think about your own budgets. What do we pay $770 for? Not too much, right? Most of the things, food payments, things like that, like most of those payments are less than that. So the point is that this is an enormous payment a month. And this is still what the federal government requires, even under the Affordable Care Act, even for people that are getting the subsidy. So it is, the point of this slide is to show you that these payments, the federal government is not footing the bill for everything. They're footing the bill for a piece of it, and the rest of it is still the individual's responsibility. And if they don't pay that, they actually get kicked out of health insurance. If you don't pay it at the end of the month, the health insurer sends you a reminder. If you don't pay at the end of the next month, they send you another reminder. And if you don't pay at the end of the third month, they cut you off, you're out. And you can't re-enroll until the following open enrollment period. So these are all real provisions, and these are very real dollar amounts. This is not $5 or $10 that people have to pay. Why don't I take a pause there? Any thoughts, questions, anything? Yeah, I'll leave a few. Go ahead. So what if you're 20 years old? Sure, you can you want to repeat it? Oh, you want me to repeat it? Okay, I'll repeat the question. So the question was, what is the rationale for a bronze plan when the expectation is, and a bronze plan pays for 60% of the cost of medical care and 40% is left for the individual. And I'll tell you personally, I'm actually a big proponent of bronze plans, and so I'll tell you what my rationale is. Is first of all, if you're 20 years old, right, and you have very low expected medical expenses, but you want to cover yourself in case you get hit by a truck. This covers you in case you get hit by a truck. If you get hit by a truck, you know your out-of-pocket maximum won't be anything more than that $7,000. You only have to pay the $220, let's say, dollars a month instead of $370. And if and you're probably not going to get hit by a truck. So probably you're going to end up saving $1,800 a year in premiums. So that's, I think, what the purpose is. What these different plans are for people with different levels of risk aversion. That's the term that economists use, is risk aversion. I may have a higher risk tolerance. I'm willing to play the cards, and if I get stuck with a big bill, I get stuck with a big bill. My mother, less so. My mother's a platinum plan type of person, but I'm more of a bronze plan type of person. So the idea is to adjust for the fact that people have different levels of risk tolerance, and that's okay. Good. Yes. So the second silver is just based on, all it does is it provides you with a benchmark of how much the federal government was going to pay. And the reason that they did it was they didn't want to create an incentive for people, like too much of a race towards the bottom, for plans to create some like bottom feeding plan that was way lower in cost to try to attract more people. But is it arbitrary to some extent? I mean, the short answer is I was there for the planning of this, and the answer is yes. Could it have been just as easily the third lowest? Yes, it could have been the third lowest. The cost to the federal government would have actually been higher if it was the third lowest. And there's another problem that people are facing right now, or that some markets are facing right now. In New York City, in Westchester, we have what I would call a robust market. I do some of my research on the New York City health insurance market. We have a robust market with anywhere between, depending on the county, 7 to 10 players. That is a big competitive market. Some counties out there, they have 0, 1, 2 players. And so if you're going to do the third, then what are you going to do when you don't have 3 competitors in the market? So the answer is yes. Any other questions? So yeah, I think so the question was, do we think that it is a question just of risk averseness in the market, or whether young people are not really looking and just looking at what the lowest premium was, right? So I think that's a great question, and that was the question not only that I asked, but that I conjectured to people that were way above my pay grade when I worked for the feds. I said, nobody's going to enter into everybody's going to go into bronze. Nobody's going to go into silver, gold, platinum. I was totally wrong. people have gone into the silver plan. That is the biggest plan by far, probably because it is a benchmark plan. And I think there are anchoring effects. People think that silver is the right plan to go to because they know the second lowest cost silver thing. But the answer is that the distribution of plans is that the bronze is utilized, and I think it's probably utilized by a younger population, but it's not utilized as much as I would have thought it would be, especially because there is the backstop, meaning like there is no situation where you ever have to pay more than $7,000. According to the plan, you never have to pay more than $7,000. So even if you have something very severe that happens to you, you don't have to pay. And a lot of these plans have very big deductibles, 3, 4, 5,000 that you're probably not going to hit anyway, unless you have some real medical event. So, all right, let me keep going. So one of the things that I said at the very beginning was that the employer-sponsored plans wouldn't change, and that was mostly true. What they did say was that employers would need to do certain things that not offer terrible coverage, right? If they offer terrible coverage, then an individual should not have to be obligated to buy this terrible coverage. They should be able to go into the exchanges. They should be able to get a tax credit. And so one of the challenges for the federal government was, how do you define terrible coverage? And so there is a technical definition that I actually worked on that basically said that the term they used was minimum value, and it basically is that it has to look like a bronze plan with a couple of exceptions. There are a couple of additional requirements. One of the more famous ones is that there will be no co-payments for preventive benefits. That means all of our employer-sponsored coverage everywhere, we all get a free trip to the doctor every year. We all get a free flu shot every year. That wasn't required by law before the Affordable Care Act. We all sort of take it for granted now that, of course, I get a free trip to the doctor. But employers didn't have, that was a part of the Affordable Care Act. Employers didn't have to do that before. Another more controversial piece is that it also includes contraception. And this is a big point of regulation now. Who gets an exception to that rule? For example, if you run a church, do you have to provide contraception? Things like that. And the levels of exceptions are under debate. And employers couldn't have annual limits on their benefits in the same way that I described is in the individual market. The last big thing that happened was an employer mandate. There was a big concern among economists that if the federal government was basically offering free money for people to go into the individual market, and you have a bunch of employers like that are high labor cost, which is like fast food, hotels, places like that, where like the salary base is low and they have to have a lot of employees, that they would just, and they were offering coverage, they would stop offering coverage, give you a little bit higher wage, and send you into the individual exchanges. And the Affordable Care Act wanted to say, we don't want that. That is something very bad that we call crowd out. And what we want is, and so the way to do that was say, okay, if you drop coverage, if you don't offer coverage, $2,000 penalty. For every person, $2,000 penalty. So this was an employer mandate. This said that you have to, if you are an employer over 50 people, you have to offer coverage. Otherwise, you have a $2,000 penalty. Okay, I talked about the show horse, which was the exchanges. I want to talk about the workhorse, which is Medicaid expansion. One thing that was interesting was that nobody in a million years dreamed that the Medicare expansion would look like this. The Medicare expansion, as written, was supposed to be a 50-state expansion. However, Justice Roberts, in the 2012 Affordable Care Act, I think it was NFIB versus Sebelius, the decision basically said that, number one, the Affordable Care Act is upheld. Justice Roberts, who was appointed by George W. Bush, sided with the 4 Democrats and said that the Affordable Care Act was upheld. The subprint in the New York Times the following day was that Medicaid, the states could choose selectively if they wanted to expand Medicaid or not, that the federal government could not force them to do this. And so many of the states did choose to expand it, and many of the states did not. The drafters of the Affordable Care Act thought everybody was getting into Medicaid. But actually, as it turns out, and this graph is about 4 or 5 months old, I think I replaced it in November of 2017 last. This is a graph of who has expanded Medicaid and who has not. What's interesting to see is it sort of looks like the 2016 electoral map. However, or rather the 2008 electoral map. But what you see is a couple of states that tend to go Republican actually decided to expand Medicaid. Any thoughts on why a state that has a Republican governor and doesn't believe in the Affordable Care Act might want to expand Medicaid? The state budget, right? Medicaid is free money for the hospitals. Regardless of whether you are in a red state or a blue state, every single hospital CEO there is, every single one wants them to expand Medicaid. Because right now the pay rate for someone that is uninsured is 1%, at least from the data that I've seen. It's something like 1% for hospital visits. The pay rate for Medicaid patients is 100%. So if you have a Medicaid patient, you are definitely going to get paid for that patient. If you have an uninsured patient, you are basically definitely not going to get paid for the patient. The hospitals see that Medicaid expansion, even if it expands to 3 or 4% of the population, those are 3 or 4% of the people. Those people aren't not showing up to the hospital. They're showing up to the hospital, and the hospital CEOs are just not getting paid for them. So every single hospital CEO wants Medicaid expansion. The tricky part is happening now, because originally the federal government was paying 100% of the Medicaid expansion. However, now, 2017 and beyond, they are starting to pay less than 100%. Of the state is having to fund a portion of that Medicaid expansion. So it is now starting to cut into the state budgets. So it'll be interesting what happens over the next couple of years. And this is the end shot. This is what has happened as a result. I said that the objective of the, our objective is to find out whether the Affordable Care Act in its goals was successful. And this, you can decide what you want, but these are the numbers as to whether it was successful. We started out with the employer-sponsored coverage. It was 169 million. Now in 2016, it was 173 million. This was not set in stone. A lot of my economist friends thought that this was going to go down to 150, 140. They thought that there were going to be a whole bunch of employers out there, the ones that I described earlier, those in hotels, those in fast food, that are just going to drop coverage, stop offering coverage. That didn't happen. And that the individual marketplace, I think it was a little smaller than expected. It started off as 20 million, and it went up to a total of 24 million, with 10 million in the exchanges. Medicaid expanded. Medicaid expanded from 59 million to 71 million, and that was without even having all 50 states in it. And the uninsured rate, this was the number that we were trying to test, went from, and I apologize, I used a different set of data from one slide to the other, from a rate of 14% back down to 8.9%. All of this, all these debates, years of articles and debates for what amounts to a 5% drop. Is it a 5% drop? My biostatisticians? It's a 5 percentage point drop. But actually, the percent reduction is a 36% reduction, because we're going from a baseline of 14% to a new of 8.9%. So it's a 5 percentage point drop. So you can evaluate for yourself whether you think that this was successful or not. But at the end of the day, this is what happened to the uninsured rate as a result of the Affordable Care Act, whose objective was to reduce the uninsured rate. A couple of key conclusions. Uninsurance rate dropped. New coverage expansion from 133%. Of poverty, everybody below 133% of poverty in the Medicaid expansion states was able to get onto Medicaid. Some states did not expand. Employer-sponsored coverage did not change. There's still a problem in the small group market. The small group market is still a mess, and the shop exchange has not been able to fix that mess. And many people believe it's because they didn't offer similar tax credits that they offered in the individual mandate. They offered some tax credits, but it was to a very, very, very tiny percent, and almost nobody is using them. A couple of other things. The Center for Innovation was created. This is the hot topic, I think, now, which is that, have you heard of ACOs, bundled payments, anything like that, that is CPC, all of these demonstration projects that are coming out of CMS, they're coming out of this office that did not exist before the Affordable Care Act. So the objective is to measure the efficacy of new models of payments. When we talk about costs, the goal here is to reduce costs. and do that in a sustainable way. So they're trying to implement demonstration projects to see, well, if you have an ACO, an accountable care organization, and you put the hospital more at risk, is the hospital going to successfully reduce costs? We also know that a bunch of new taxes were created, and they still exist. The Medicare tax, the investment income tax, oh, it was 3.8% on earnings over $200,000 a year. I think it's 250 for a married couple, 200,000 for a single person. Large employers are penalized if they don't offer coverage, and individuals were penalized if they did not purchase coverage. And this was repealed in the 2017 Tax Reform Act. Is it effective now? No. The Tax Reform Act passed in December of 2017. The individual mandate is effective in 2018. If you don't have coverage this year, you will get taxed. You'll get, I believe it's 2.5% of your income. That is how much you will get taxed. And in 2019, that is when it is repealed. A couple of myths. Obamacare will lower the cost of care. It was never meant to. Obamacare will bankrupt the country. I think that time has shown that that has not been the case. Obamacare will cause employers to drop coverage. That has not been the case. Obamacare included death panels. Remember death panels? Weren't those fun? Death panels was actually something that came out. It was a proposal by a Republican of Iowa, Chuck Grassley, and the objective was to have primary care physicians paid for an end-of-life care visit with new Medicare recipients. So if you're a new Medicare recipient, you go to your PCP and you want to talk about end-of-life care with them, that doctor should get paid for that visit. That's what a death panel came from. But it got included in the Affordable Care Act, and away we go. And last, this is my personal favorite. If you talk to me afterwards, I'll tell you the whole story behind this. I won't talk about it now, but this is a goodie. Members of Congress and their staff must be covered by Obamacare. And now there are 11,000 members, and the DC Exchange is one of the best run because all the members of Congress and their staffs have to get covered by. They don't get insurance through the same plan, FEHB, the Federal Employees Benefits Company that used to do it. So yeah, the Affordable Care Act forced all of those members of Congress and their primary staffers to be a part of the exchanges. So I'm just going to talk for a minute about Trump and the changes with Trump Care, and there's really been only one change. So one thing that's interesting is that the individual mandate is a tax, right? If you don't get insurance coverage, you are taxed. But repealing the tax, so taking away money from the federal government in the form of a tax, actually reduced the cost to the federal government. This is totally counterintuitive. How did it do that? Go ahead. That's exactly right. So all of those people that are pushed into the market by the individual mandate, most of those people are getting subsidies. And the amount of subsidies that they're getting is this much, and the amount of tax that they're losing from repealing it is this much. So actually repealing the individual mandate saved, even though you're repealing a tax, saved the government money. Fewer people now get a tax credit, right? Can you just read that off the slide? Just kidding. And the estimate is that the number of uninsured are going to increase by 4 million people. But it could increase all the way up to 13 million people by 2027, an additional 13 million people. That is CBO's estimate. Where does CBO get their estimates from? The answer is guys like me. I work for the Joint Committee on Taxation. I was an economist. We worked hand in hand in developing the model that gets used. They use the best academic literature, good for academic literature, to try to come up with the estimates here. However, they don't know what's really going to happen. These are the best estimates that are available, but they don't really know what's going to happen. And so I thought it was interesting that I'm actually going to skip this slide for a second and come back to it. So here are the estimates that they came up with, was that 4 million all the way up to 13 million people. Sorry if this is too small. But what's interesting is this. So what I like about this talk, and I've been giving this talk for about a year now, is that it literally changes every time I offer it. And the most recent thing happened from a Kaiser Family Foundation study that happened just the other day. And what they came out with, and this was in a lot of the papers, was that they said, how many of you that have insurance in the individual market got insurance because of the individual market? only 20% of the people said that they were aware that the mandate is in effect in 2018, but not in 2019. And 75% of the people that buy coverage in the individual market said it didn't impact them. That was not why they bought coverage. So the question is, while these numbers are the best that the federal government has to offer, and I think that you'd be, covered in if you use them, and you'd probably I wouldn't feel comfortable using another one. It doesn't mean that this is what's going to come true. It's very possible that something that happened over the course of the last 5 years is that the individual mandate became ingrained in our culture. We believe that there is a law that requires whether or not the law is in effect or not, and as a result, more people are buying insurance, and that the impact of repealing the individual mandate may not be as intensive as the economic models would predict that they are. So we don't really know what's going to happen. Only time is going to tell. And particularly in 2018, it's going to be interesting because there's so many people that have no idea what's going on in 2018. You guys are probably the only people around that know that in 2018, the individual mandate is happening, and in 2019 it has been repealed. I'll say one, I'm at time, so I'm going to open it up to questions. Any thoughts, questions? No? All right. Oh, I can, are you going to pass around the mic?
So what are your thoughts on because of the consolidation of healthcare companies, like insurance companies, how do you think that's going to affect the marketplace? I feel like it already has, but do you think it's going to make it obsolete, sort of, or if we
it won't make it obsolete. So I think there is substantial evidence in both the provider side market, meaning that when hospitals consolidate, prices go up, and that when there are fewer, I was literally just researching this just before I came here, that when there are fewer insurers in the market, that there is evidence that prices are higher. So I think that market consolidation is not necessarily a positive thing. At least the evidence has shown that it is not necessarily good for consumers.
And like the marketplace that we're using, like for the individual marketplace, I mean,
Sure.
It's making it more expensive to use the individual marketplace. The fewer healthcare companies that we have in it, right?
Yes.
And in time, if there's like 2 companies left, that's really all it's going to be competing, right?
Well, I don't know that that is the case already in many counties, many rural
right.
counties. New York, I don't think that's going to be the case. And what we've seen has actually been really interesting, which has been that Medicaid has always had some options for managed care. And what we've seen is companies like Fidelis, who I used to work for, Health First, Metro Plus, Affinity, all of these Medicaid managed care companies have competed in the exchange markets and have actually done very, very well. They've offered narrow network products. They have a relatively low rate of pay. They have a tightly managed product, and they have been pretty successful. And so people are flocking to them. What's also interesting is that in New York, our market, there were 3 startups. 3 startups in the health insurance market. Who ever heard of a startup health insurance company? Health Republic went out of business in grand fashion in 2015. They were supposed to go out of business December 31st, 2015, and they were losing so much money. They were not paying their bills that the Department of Financial Services, our Department of Insurance, closed them on November 30th and literally told all their members, you are now in Health First, you are now in Fidelis, you are now in Blue Cross. They just scattered the members. Crazy. I've never heard of anything like that happen. Care Connect, Northwell Health, the big behemoth of Long Island, where I was a member until December 31st, 2017, when they closed their health insurer because it was losing hundreds of millions of dollars a year. And then the third one is Oscar, the darling of the tech companies, started by Josh Kushner, brother of Jared Kushner. And they have lost about $250 million in New York State in the last 4 years. Now they've turned it around a little bit, meaning that they didn't make money, but they lost a less intensive amount of money in 2017. But the startups that have come into the market have not done particularly well. They've done very poorly, and 3 of them have gone out of business. Amy.
since the Affordable Care Act. So for example, what I'm referring to is risk-based contracting and value-based payment. Can you speak to some of those new service delivery models and how you see their impact on healthcare providers?
Sure. This is not my area of expertise, but I am always happy to speak on anything. So, so I will give you my relatively uninformed opinion on it. So ACOs. So one thing that we've seen in New York State Medicaid has been that there has been an enormous push in New York State Medicaid to adopt value-based purchasing models. And the value-based purchasing models are actually somewhat simple in that they assign a population to a provider, let's say Westchester Medical Center. They'll have 100,000 patients, and they'll look at that 100,000 patients and say, last year, those 100,000 patients, they cost $10 million. And if they cost $9 million next year, you get to keep, there's $1 million in savings. You, Westchester Medical Center, you get to keep 500,000 of those dollars, and Medicaid will get to keep the other 500,000 of those dollars. So what we have seen is that I think a lot of these organizations that are responding to these incentives and doing their best to reduce the cost of care and trying to come up with saying, okay, well, when are our avoidable ED visits happening? When are they happening? Okay, well, what if we open an urgent care center next door to the ED that instead of costing $3,000 for someone to just come in and out for over the course of 3 hours, we can do it for $500. So I think we have seen in the course of the last just couple of years, particularly in New York, that some of these models, that management has responded to some of these models by trying to create new models that are going to reduce the overall cost of care. But there is one big caveat to this, which is that now these big hospital systems are trying to play both sides of the coin because, and not to anything that they have done wrong, but they are still getting paid for every volume, every ED visit they're getting paid for. But at the same time, they're sort of losing money from the ACO model, but they're still getting paid for them, but they're still losing money. So they're not quite sure what to do. They have two different, essentially contradicting incentives going on at one time. And so I think we're going to need a more intensive shift in order for there to be real progress.
But I just want to, acknowledge that I think you answered the question really well.
Oh,
and
thank you.
Really great job and on everything. And I also want to just make a comment because at the beginning of your presentation, you talked about Medicaid and you talked about all the financial pressures. And we're all trying to control costs, out of control spiraling costs. Do you have any comments regarding, I think it was Anita Cranes in healthcare, which I recommend to any of the students to start trying to read Cranes. It's very interesting in terms of the direction of healthcare service delivery. But what's happening now with CMS, with home healthcare agencies, because there's the new information about how they're trying to restrict Medicaid dollars to home healthcare agencies?
So is that referring to the fact that they're limiting the number of Medicaid, the number of home healthcare agencies each Medicaid plan can contract with?
Yes, in order to try to, reduce the cost, the Medicaid costs. Now what CMS, Centers for Medicare and Medicaid, is doing is making it a policy that you can't contract. Medicaid will only contract with fewer home health care. What does that do? Maybe to address to the group as an economist, what does that do?
So I can tell you, so I worked directly on this issue when I worked for Fidelis. I spent a disproportionate amount of my time on the managed long-term care market. And what I found was that at Fidelis, which is one of the biggest Medicaid long-term care, we were sending checks out to, I don't know, 100 different long-term care companies. And it was unclear to me that it is efficient to be contracting with that many different providers. I think it is better to have a little bit more tightly managed network than what we had. Because remember, I'm talking about 100 or 200 different providers for 5,000 or 8,000 patients. It's not like we're talking about 1 million patients where you need hundreds of PCPs or thousands of PCPs. This is not a lot of patients. And this is not a lot of home healthcare aides, right? Some offices had 5 or 10 healthcare aides. Some offices had 200, like visiting nurse service, right? Has hundreds or maybe even thousands. So I don't think it's necessarily a bad thing. So whereas I told, I answered one of the previous questions that there more competition or rather consolidation may be a bad thing. This is an area that I've seen some mom and pop shops that do not have electronic medical records. They're not organized. They don't do a great job of training. So I don't think it's necessarily a bad thing to have a little bit of required consolidation in this area.
I agree with your comments. I just want to add a different perspective. And it's not, I'm not disagreeing. As the chairman of the board of directors for visiting nurse services in Westchester, Putnam, Rockland, Dutchess, and the Bronx in New York, what I'm seeing as for organizations like the one I chair the board, it's a real win because it's just going to pump our volume up. But we're seeing right now in New York, and I use this word deliberately, a tsunami of elderly people who have dementia, Alzheimer's, and other. We've never had anything like this before. So there's going to be a real issue, a real problem with how to respond, timely initiation of care, which CMS and OASIS actually grades home health agencies on timely initiation of care. So one of the unintended consequences is whether all the big gorillas in the room, like VNS, will we be able to treat this tsunami of elderly patients in the manner with the respect that they deserve to be treated?
So so as an economist, I assume away a lot of like problems that actually exist operationally. What I'm assuming away is that all of the people that work for the smaller organizations with 5 or 10 that do their billing by hand, that all of the home health aides, they're not going to leave the market, that they're just going to get a job at VNS or one of 20 or 30 big organized firms. That is what I'm saying is probably not true, right? What is probably going to happen is there's going to be some dissipation of some of these people who are going to lose their job, and then they are going to go do something else because maybe they didn't love the job to begin with. And so I do have a real operational concern that there is going to be a reduction in supply that the reduction in supply that you're concerned about.
Thank you. Great answers and great presentation.
Any other questions?
Why you think that North Wales interest or going into insurance failed so abysmally. Geisinger has been doing that closed system methodology for years and has seen gains and efficiencies. Why not Northwell? I mean, they're just so huge.
Yeah, I'm glad you asked. So I'm writing a paper. I'm writing a paper on this right now, and I gave a poster presentation on this. And so my hypothesis, which is not really testable, is that, but hopefully within a year I'll have something that can test it, is that I don't think they got very good network rates. In other words, they did not negotiate with themselves well. Period. End of story. Like that's it. They didn't have a broader network than anybody else, I don't think. And I think Oscar has the same problem. And I think that Health Republic had a host of problems on top of that. Northwell had a network. Of course, they came into this with a network, and they basically, and my anecdotal, because I made a couple of phone calls about this very question to people, and my anecdotal experience was that that people that negotiated with Care Connect said, this is a commercial plan, and we're going to give you a commercial rate. Maybe we'll give you 5 points less in terms of what the contracted rate is. If they were negotiating for the same exchange plan with Metro Plus, a Medicaid plan, that they already had experience with, or Affinity, or Health First, they started at the Medicaid rate, which was much lower. So if you look at the Medicaid plans, they're all making money, or at least breaking even, at a lower premium rate than Care Connect was at. And so I think that was their primary problem. Any other questions? All right. Thank you very much.